Okay, good morning or good afternoon. This is Steve Sirheinrich. I'm a co-founder at Curvo, and I am really excited today that everyone's joined this call, and we've got a tremendous panel to talk with from Harris Health. And the topic today is about CRM, sourcing and contracting. This is our Curvo Quick 30. We do these webcasts monthly, and they are available on recording. So if you want to listen again, you can go to the website or catch some of the previous ones on total joints, sports medicine, and some other categories. Before we get started, just a little housekeeping. We love questions, and I think this presentation is going to, or this conversation with the Harris Health team is going to spark a lot of questions for you. I talked with Stephanie, who's on the call earlier this week, and it got me really excited about what she's going to share and her team. So if you do have questions, don't hesitate to ask, and you can see the Q&A button in your Zoom panel menu there. You can go to that and ask a question, or you could go straight to the chat and ask it to the entire, all attendees. And the chat's kind of nice because you can get feedback or answers from other attendees on this webcast too. So feel free to use either one, but please go ahead and ask questions. We'll address the questions at the end. So we do call this Quick 30. There's a lot to talk about, so just a warning, we may go over 30 minutes on this. All right, let me go ahead and introduce our panel. So this group is from Harris Health, and from the physician perspective, we have Dr. Nasser Lakis. Dr. Lakis graduated from the American University of Beirut. He has a combined Master's of Science and Medical Doctor degree. He completed his residency in internal medicine at Baylor College of Medicine in Houston, Texas. And he completed a fellowship in general cardiology and advanced interventional cardiology there as well. He is a full professor of medicine at Baylor College of Medicine, and he's currently chief of cardiology at Ben Taub General Hospital and the program director for cardiovascular diseases and interventional cardiology at Baylor College of Medicine. So we're thrilled to have Dr. Lakis's opinions on, it's a Q&A with him that he's not live on this webcast, similar to the previous ones we've done. We do have Stephanie Craddock, Benjamin Etuk, and Doug Kramer live on the webcast. So Stephanie is Materials Management Analyst on the Value Analysis team at Harris Health. She has a degree in Accounting and Finance from Prairie View A&M University. She's currently responsible for the value analysis activity for the procedural areas, lab, and support services for Harris Health System. And she's been in this role for 9 years. One thing about her bio that I really liked is that she said she's driven to maximize savings opportunities through standardization and believes fostering a collaborative relationship with clinical personnel of all levels is an essential piece to success. And I think you're going to hear a lot about that from Stephanie today on how she's been working with Dr. Lakis in this CRM sourcing and contracting project. So Benjamin Etuk, he is a registered nurse with a specialty in intensive care nursing and wound care, and he has a tremendous amount of nursing experience. He's been working with Harris Health System for the past 22 years and currently working as an operations manager with the Harris Health System in supply chain management, specializing in value analysis. He's over the Harris Health Supply Chain's Value Analysis program with 5 committees. So there's lots of work that Benjamin's doing at Harris Health, and you'll hear about that, I think, as well. He also holds a Bachelor of Science degree in nursing from the University of Texas and a Master's in Healthcare Management from Houston Baptist University. And last but not least, Doug Kramer. Doug has over 20 years in healthcare supply chain management experience in academic institutions, including Christus Health, UT/MD Anderson, and currently serves as Administrative Director of Supply Chain at Harris Health System in Houston, Texas. So Doug also has a registered nurse undergraduate degree and a master's in healthcare administration, from both of them from Texas Women's University. Doug began his career as an RN working as an ICU nurse and OR nurse in Texas medical hospitals before moving into supply chain. So welcome, Stephanie, Benjamin, and Doug. Thank you so much for joining the call.
Thank you.
Glad to be here.
All right, let's go ahead and get started. We'll look at some of these questions from Dr. Lackas. These are, anybody who's seen our webcast before, sees these as standard questions that we ask. And so we're seeing some similarities in his answers. The first one in particular, well, in general, we see that quality of care is number one in importance, but price of the products is second. And so it has a lot of weight. What I see in this too, from his answers, I can tell very much that he is very aligned with supply chain. You've done probably a lot of work over the years to build this relationship, but it sounds like you have a really nice cadence on how they look at new medical devices, where they have a process every 3 to 5 years to look at the contracts, but every year they're looking and discussing service levels and product issues with the supply chain team, and also have a way for the doctors to be able to add products within the formulary. It's also research and learning-based institutions, so of course there's a lot of emphasis on that quality or those outcomes and quality of care. A couple questions though I wanted to highlight. The one on how do you learn how much a device costs? I think this is really good, and I think we're going to see and hear unpack this quite a bit in the conversation. But they put a process in place to have a punch-out catalog for all standardized procedure products with contracted pricing loaded already. So they're able to see that, and it looks like they're being audited on that on a regular basis. And he also has visibility in reimbursement levels, which we don't always hear from the surgeon. So Harris Health Team, I'm curious, what are your thoughts where these answers are what you expected? Any surprises here, and any ways you could elaborate on some of the answers you see from Dr. Lackas?
Well, I think just looking at about how we know about reimbursement, you know, Harris Health is a safety net hospital for Harris County, and our patients are mainly indigent. So, you know, reimbursement is a concern. We do have probably about 25 to 30% Medicaid and about 15% Medicare, and a lot of that is, you know, straight out DRG payment. So some of it is anecdotal from the point of view of the Dr. Lackas and his team. So it is, you know, some of it we don't really get paid any more than the DRG, although some of, you know, the big devices, you know, there is a max cost, and so reimbursement's not always the issue. It's really directed towards cost savings. So, you know, and just as far as discovering how much a device should cost rather than what it is, you know, we do work with Curvo. They assist us with our analytics, and we use Premier GPO, as well as we also use our Harris County purchasing agent's office to bid out our RFP product categories such as this.
Okay.
That's good. And thank you, Doug, for that clarification, extra information on reimbursement. This is Stephanie, and our punch-out catalog, which is actually an extra interface that's in our PeopleSoft system. It actually came about, I think, in 2012 or 13, and it was really important for those procedural areas like OR, the cath lab, interventional radiology to have quick access to their products and to their contract pricing, because we're looking at contracts that have an upwards of 1,000 plus items. And so to manually have to look for those items in our PeopleSoft catalog without the punch out would really been time, you know, prohibitive for the people that order for the physician. So in order to take that excuse out of not having that transparency and not ordering something and really not understanding the cost and kind of like utilization, our MIS systems team, which has been a great partner with Value Analysis as well, and they're a part of the supply chain, they instituted the punch out, it's called Procurement Suite. And it is an excellent resource for our procedural areas and for the contracts that have a lot of items. And so we automatically upload those particular items once you review contracts, and it takes about 24 hours overnight for that stuff to sync. And then they have visibility, and those items are accessible to the end user departmental order. So that's very important. So MIS systems, along with your value analysis process, that's very important in order for there to be transparency in contracts and how much things cost.
Yep. Okay, well, thanks for that clarification, Stephanie and Doug. I am really anxious to just jump into your CRM sourcing project. So let's go on to the next slide. This has, everybody can see who's talking. Why don't you, Stephanie, if you don't mind, go ahead and give us some background, an overview of this CRM project.
Okay, sure, no problem. So I'll try not to be too long-winded, but we actually completed, our CRM project last summer of 2017. Now, historically, this has always been a product category that has kind of yielded a lot of scrutiny. It's always been a product that's looked at administration, and everybody wants to kind of know what's going on with CRM. So traditionally, this has been my third time actually sourcing this particular category, and with Dr. Lackus and his team. So as we said, that ongoing long relationship was definitely put to test this particular time. But we were also wanting to, our focus was to actually go within this particular product and actually do some standardization within the subcategories pertained in CRM. We know we were heavily using St. Jude, with Medtronic kind of being second and Boston kind of being third. So there was absolutely room for standardization. And traditionally in the past, we did try to go to one supplier for CRM, but that did not work for different service levels reasons. So going into this one, we really kind of wanted to really do a deeper dive, really have some ongoing, a lot of conversations with Dr. Lackus and his team, because we were also dealing with two suppliers that were on Premier, and we were dealing with St. Jude that was not on the Premier contract category for CRM. So we knew there was a lot of opportunity, and we knew this was a hot button topic with administration. And we also knew that in looking at our usage and working with Drew, we also knew that we were using a lot of biventricular devices. So across the board, just initially looking at the usage, we saw that we really wasn't standardized to anybody across the board. It was just, kind of all over the place. And even though St. Jude was came in first as far as utilization, there really wasn't any, like I said, product subcategory standardization. So we knew there was opportunity, and we knew we had to gingerly kind of work with Dr. Lackus and get his input and get his buy-in from the beginning, before showing spreadsheets, before kind of engaging other resources. We wanted to sit and talk with him and get his thoughts on what we felt was important during this time, before we started the actual kind of review process. So there was a lot of prepping, a lot of discussions that had to be had before we dove deep down and kind of into the data and into the spreadsheets with Dr. Lackus. There was some, testing the waters with our relationship, and kind of just, what are your thoughts? What do you want to accomplish with this particular contract review?
Okay, that's interesting. So Dr. Lackus obviously was key in this. Can you unpack the relationship with Dr. Lackus? I'm assuming, I know you've known him for a while, but has it always been, it probably hasn't always been at the level it is now. So could you talk about how you built that relationship with mutual respect with Dr. Lackus?
Sure, and I'll also have Doug kind of chime in too from an administration point of view. So give everyone a call some history. Is that I started here at the inception of our value analysis process. So when I started here, value analysis was we were just formalizing our committees and formalizing the different stakeholders that would be involved in each of the contract, in our contract review process. So there was a lot of heavy lifting that we did at the beginning to build those relationships with our physicians, because at first value analysis was a dirty word. It was, the physicians thought, oh, I have supply chainers coming to tell me what to do with my practice, my protocols, and how basically I should practice, medicine. So we had to basically build their trust and get them to understand that, quality is very important and cost absolutely should be looked at. So we need your clinical expertise to work with me so we can help get the quality product at the best possible price. So that's why it was called, value analysis, because our process exists in sync with our clinical personnel. So it's just not supply chainers sitting around a table talking about contracts. We absolutely depend and need the clinical input from our clinicians. So our relationship started off very rocky because there was a lot of education that had to be done, and there was a lot of trust that had to be built. And I will always say that with each new project, it's like starting the relationship over again each time, because each time you're building trust, each time you're working on your relationship. So you can't count on past wins. You have to just take it as it goes. And each opportunity that we have to work together is an opportunity that I'm going to take to kind of start from scratch and just rebuild our relationship with each and every project. So it wasn't always, I'm not going to lie and say that it was always perfect and great, because it's been 8 years and 9 years of work with the cath lab, you know, because every physician has a way in which they want to practice medicine. But when we sit with them, we show them pricing, we show them utilization, and we show them opportunity, then it starts to get them to thinking about supply chain and supplies differently. So, you know, there were some things that we had to overcome in that relationship. And Doug can talk about, from an administrative point of view, you know, his relationship with the cath lab personnel and clinical, you know, anyone clinical as well, too.
Okay, and as you, Doug, maybe if you could elaborate, are there any administrative or any Harris Health incentives set up for the cath lab physicians to work with supply chain? Did you have to do anything with your administrative leadership to help build that relationship, or any challenges there you had to overcome?
Yeah, there certainly were. So, you know, Dr. Lackas and the cardiology team, you know, we are an academic facility. So, you know, up to this point, they had been all about looking at every possible vendor to be able to train their fellows and residents on. But also, it's all about treating the patient. So the more money that they are able to save, then the more patients they can treat. So administration had been at odds with, you know, biventricular pacers were $8,000 to $10,000 more than a regular device. So they, the Ben Taub administration had already told them, the cath lab, not to put in biventricular pacers, period. And they had, but clinically there is a necessity for them. So we kind of took that opportunity to go back and have additional discussions with Dr. Lackas about how we could help them and he could help us. And he provided the suggestion that why don't he thought possibly we could get biventricular pacers at the same price as a regular defib pacer. And so we went back out to bid, and Dr. Lackas agreed that if any vendors would do that, he would use those vendors exclusively. So we went back out, we found 2 vendors that would do that, and we awarded, and that became, then they became very interested in that occurring, because then they knew they could, you know, kind of smooth over their relationship with the senior leadership at the facility, as well as accomplish our savings goal and treat additional patients. So that was, you know, we were able to pull that off through the RFP process, and it was really a win-win. And we could not have done it without executives administration giving them a little push.
Wow, that's really interesting. So there were unique challenges with the biventricular pacemaker products, and you actually were able to get Dr. Lackas and the cath lab team to agree that they would use the vendors that were able to give you pricing at the same price as a regular pacemaker. And how did you then go and communicate that to the device companies?
Actually, we sat with all 3 at the time, and we said, hey, this particular sub product, here's what's going on with biventricular, here's what we have going on with administration, and here's our service goal. So help us we're looking for a partnership, basically. And along with that biventricular award, you would also get, hence the pacemaker. So we let the suppliers know there was additional sub category that was up for grab as well, too. And everyone knew all 3 suppliers that were in the mix knew kind of who they know how they're being utilized in the cath lab. So they absolutely understood the opportunity that was presented in front of them. So we gave them a threshold, because this is a threshold we have to meet in regards to pricing. And we want you to go back to your corporate people and let them know that this is how we're going to be sourcing this particular category. So hence your award for biventricular devices would lead to an additional award exclusively or 90% of the business in the pacemaker. Because considering all three things being equal with the pacemakers, which we also went through that information with Dr. Lackas too, could this possibly being done? So there was a lot of work that we did. Hey, if this happens, Dr. Lackas, you're not going to have a problem with moving majority of your business, your pacemaker business, also to the supplier that wins the biventricular business. And we had those, very transparent dialogues with Dr. Lackas. This is what we're trying to do. This is how we can accomplish that. But we also need we need your buy-in too, because we don't want to make an award and 6 months later, you're still doing the same thing. So there was a commitment on both sides. So all three suppliers knew what they were up against, and they knew the opportunity that was presented in front of them. So that's how we led with, the sourcing process. And each supplier, they definitely, two definitely came back to play, and they were very serious. And that's how we were, able to get, over 600K of savings, because our biventricular devices were in upwards of, 20 to 25 to 28 to almost 30K in pricing. So you're talking about taking, in upwards of 10K of pricing, off for those particular devices. So it was a major opportunity, but they had that promise of additional exclusivity and additional, volumes, excluding change outs when, when a patient comes in and they're using someone else. So that was excluding like change outs and accessories. So, we definitely took a different approach, but we definitely had to have those candid discussions with each and every supplier in a separate meeting. And we also had buy-in from Dr. Lackas. If this turned out this way, this is your commitment to that supplier that's going to win your business.
Mm-hmm. Well, that's really impressive that you got Dr. Lackas's commitment there. What were any challenges you had in getting that commitment from him?
I think we dodged a bullet on that. If all of them had come back and agreed to do it, then they would have got nothing out of it.
Mm-hmm.
But also, if that would have been the case, then that would have really allayed the fears of executive administration of having to pay, a good 30% more for a biventricular. Then, if they had all come to play,
yeah,
and it wouldn't have been an issue. We could have got our savings and had access to all vendors, but they all didn't come. And as far as we can tell, and we look at the usage on a regular basis, he's keeping the commitment.
Right.
And one other point to talk about that is also the importance of your data as well too. If data is important, you can't actually make those dashboards and actually have those awards there in scenarios without data. So that was very important too. So every time we wanted to show him what a particular award would look like, we would change our dashboard and our pie chart. This is what that scenario to look like. And so able to, working with Drew and having just any kind of, analytic dashboard was very important, because I could readily, when Doug needed something to give to our VP or our chief medical officer at Ben Top, Stephanie, what the scenario looked like, I was able to quickly, use the Curvo platform and send that dashboard out. So, analytics is very important, be able to shoot those things out timely, to administration, to your docs. Because a lot of times they don't understand spreadsheets, but they understand that pie chart and that scenario that awards their scenario and the savings that are laid out with that. So that's very important.
Yeah, absolutely. So, and if anybody who's on the call who doesn't know Drew she's talking about Drew Mays, who is Director of Customer Success at Curvo. And so you really had a mandate from your administration that they did not want you using these biventricular products due to the high cost. And so, but you needed to use these because it's important for the patients. And so Dr. Lackas, with using information resources you have, showing him your utilization, showing him price targets, I suppose, you're able to win him over to be on your side, at least come up with a plan. And you went together to the device companies with this plan, kind of a united front, that if they were to level set that pricing on biventricular, they would get all of his business. Let's talk real quick about how you approached Dr. Lackas with the, finding what the right price in the market would be for this product.
We knew how much we were paying traditionally, what we had paid for biventricular. So we knew that data. and we knew how much we paid for the regular pacers, so we knew that particular data, you know. So once we knew our price points, we kind of knew what our threshold would be. And like I said, they knew, like NF in the cath lab and his support team, they knew how much you were paying and knew what was up for grabs. So what was secondary is, you know, the pacemaker business. We know we were paying the Cadillac price, you know, from one supplier for the pacemaker. So we also knew that that was, you know, we saw across the board, you know, the opportunities. But really what's important, Stephen, is kind of saying all things being clinical and looking at all the different modalities that are available from all three major players. All things being equal, could you possibly switch from this supplier to this supplier and still be able to administer the same level of patient care? And so once we work through all of that minutia and kind of data, like, you know, and just really tell me, Dr. Lack, it's like, what makes this supplier so special? You know, why can't you move from this supplier from pacemaker? What modality, what is so special about this one? And once we kind of got down through that minutia, and hey, it's just kind of really what I was trained on. I'm used to it. I like it. I'm like, you know, and so once we got through that and we realized, oh, okay, it's, you know, it's familiar. He's familiar with it. It's not saying the other suppliers are not good, but he's familiar with it. So, but he's not, and I also showed Dr. Lackis with the utilization reports that, yes, you are giving this supplier that much volume in business for pacemakers, but he's not being fair on the price. Like for all that exclusivity, you're getting nothing in return for the price point. And so, you know, once we showed him, like once we drilled down and showed him that, you know, that, oh, okay, I can use somebody else. And then we also did a lot of benchmark pricing as well too. So that tool was actually, you know, helpful. You're looking and you're seeing what other size institutions are paying, you know, for the volume that you're giving, you know, this particular supplier. So benchmarking is very important. So you can absolutely see, you know, what are your goals. So that helped make things reasonable. And of course, you know, we're a mid-sized institution. You know, we're not as big as the Kaiser Permanentes and as, you know, as big as some New York acuity. But however, we do, you know, there are some, you know, we did have some areas, we do have some areas for opportunity, and that benchmark pricing and showing him that utilization, like what are you paying for exclusivity based on benchmark pricing? So it's just not worth it with all things being even clinically from all three major suppliers.
Yeah, that's interesting. And this is, I just pulled up a slide to show everyone listening here what, you know, what's happening in the CRM market right now. We're seeing prices down about 1.44%. Top vendors have 59% market share. And what's very interesting is that the price performance to market share and price performance to volume, it's direct, but it's weak. So, so a lot of you out there, you may have room to move or get some better savings. And if you look here, you can kind of see within this graph that, you know, there is some correlation. You see the bubbles getting a little bit bigger as you move to the top right, but it's still a weak correlation. And so you were looking at, I think, Medtronic and St. Jude Abbott, right?
Right, that's correct.
Yeah, and so we can see where you were right around 50th percentile, and I know that you did really well on this project. As you can see here, there's a lot of room. You could look at this and maybe share this with your surgeons and see, help them understand too that you're not getting a lot for that exclusivity. You had a lot of market share. And then you can see the same for St. Jude Abbott, now one company. So could you talk to us a little bit as we kind of wrap this up and go to questions? Can you talk to us a little bit about what your outcomes, what your results were of this project?
Sure. Our results were we were able to, I don't know if I can name a supplier, but we were able to standardize to one primary supplier for biventricular devices because we were using all three with no exclusivity and then paying a very high price for those devices. And so and then as a result of that biventricular device, we were able to standardize to that same supplier for pacemaker. So we were able to stop using the Cadillac high price pacemaker and use a pacemaker that offered the same clinical outcome at a better price because of the biventricular award. So, and then, you know, ICDs, we had like maybe like a kind of like a 30-30 split with ICDs. And then, you know, we put our accessories and change outs in that as well too. So that was like our pathway. So in upwards, we saved over, I said 600K, we saved over 700K in this particular product category for us. So that was really huge because, like I said, we were using a lot of biventricular, but we were using all 3 suppliers, their Bive devices, and we were paying a premium on them. And then we were using a supplier's Cadillac pacemaker and almost in an exclusive manner, but we wasn't really getting a good price at all. So you can see how those 2 major subcategories really led to a lot of savings and standardization as well too, with outcomes still remaining the same.
That's great. And as administration, did they recognize the good work you all did and how you worked together on this?
Ben, you want to talk about that? Ben is being quiet. He's back here being modest, but he's not that quiet, just to let everyone know on the phone.
So, I mean, we present all of our value analysis projects and the savings through our system-wide standardization committee. And so, you know, this was a major win in interventional cardiology, and we had not been able to get anywhere really past the GPO pricings, or any attempts at standardization really had been resisted. So you know, it was acknowledged, and I think Dr. Lackas certainly appreciates not getting pushed on by his executive administration.
Yeah, it sounds like a win-win-win where everybody got what they wanted on Harris Health and on the supplier side too, with the increased business. So we're at the little past the 30-minute mark, and so I want to open it up to questions to the audience. So just hit the Q&A button and feel free to type in your question or use the chat. And just to get us started, I would like to ask a question. You've got a lot of people on the call who are in your position and they may or may not be thinking about the CRM, but even other projects. What advice would you give to other supply chain leaders on this call about how to approach this category or your surgeons in this category?
I'll let Ben answer. I'll let Benjamin Etuk, he's my direct report, answer that question because he's over all of us as well as the procedural areas and OR anesthesia. So he's, with that nursing clinical background, he's definitely sits with me. He's definitely in front of physicians a lot of the time.
Okay, and Ben, as you answer that, I think the audience would also like to know, we talked about a lot of the good things in this process, but also we've talked about what went well, but what didn't go well, maybe that could be some good lessons learned for the people on the call too.
So I think one thing was, even though, we did come up with some savings, it really took 2 RFP processes. I mean, this was a great effort and a great final outcome, but it took a long time, and we did not thoroughly know the market, and we would never have gotten there without the individual discussions that we had in the cath lab with Dr. Lackas, and just by sending an email and a memo and some spreadsheets to some physicians, that you're going to lose out on knowing, the really specialty things that go on in the market that affect their decisions. And you don't get a feel for the relationships that the vendors have with those physicians. So to help understand that helps you get a lot of extra insight on how to craft the RFP and to create the ask and generate what is the physician want out of this within your means. So, because we cannot offer gain share here because we're a county facility. We cannot offer bonuses or anything or split, do a savings split, any kind of thing like that.
Okay, that's good. And we have a question from the audience here. It's, did it help having clinical team members on the project outside of the physician? So I think, knowing that Ben and Doug are both RNs, have a history in clinical. I don't know if anyone else on your team is that way. And so curious how that helped with the project.
Yeah, Steve and everybody, this is Benjamin Etok. I think Stephanie and Doug, they have handled this very well. But from a value analysis standpoint, when we started, that value analysis was there, but it wasn't really there. We had to build that relationship, as Stephanie had mentioned, and with clinical collaboration with one of our directors over at the CAT Lab, Anna Davis, we were able to do lots of things because without that clinical expertise, we would have had several challenges and other areas that we would have had a little bit of problem. But it is fair to say that with the clinical knowledge, we were able to at least dialogue from that platform. Mm-hmm. Even though Stephanie Craddock did a lot of heavy lifting, but when you're dialoguing, from a clinical standpoint, from a clinician to a clinician, that was very that at least gave us an opportunity, to reach the 3-yard line.
Mm-hmm. Yeah, that's great. And so anybody listening who's, if you don't have the clinicians in your supply chain, it's really a big plus to have, whether they're on value analysis or employed in the supply chain, but get those RNs, or even some hospitals have a medical director of supply chain. That's a big plus in that being able to communicate clinician to clinician. So I think that definitely made a big difference here in this project. Okay, we have another question from the audience, and it's around physician champion. Sounds like Dr. Lackas was your champion, and they're asking, what advice would you give to help identify a physician champion for your project? Are there any I'm going to add on to that. Are there any characteristics about Dr. Lackas or other physicians you've worked with, and have to be this project necessarily, but helping someone identify that physician champion who will work with you?
This is Stephanie. I also work with Dr. Chen, who's head of our interventional radiology too as well, and he is the chair, one of the chairs for the procedural areas value analysis committee. And some of the characteristics I look for is be a great communicator. That's really important, but also someone who understands the business of the business. And I'm not gonna don't scream me for saying this, but usually our newer physicians, they kind of have a business perspective too on the products that they use, and they have an understanding of supply chain. It's not all the time what I'm used and I've been trained on, but what are my other options? Where else can I get the same clinical outcomes, but at a lower price? And they're very cognizant of price points. So you're looking for somebody who is going to know and understand that hospitals, we have to absolutely look at cost and the cost of supplies, the cost of doing business. That's very important. So to get a doc who can communicate, who's not afraid to have those conversations, those uncomfortable conversations with other physicians, and who really is able to want to partner with supply chain. So they have to have that, the old school thought of, I'm going to use what I'm going to use. I don't care how much it's going to cost, and this is what I've been trained on. They have to have some kind of openness to them, to learn about supply chain. And then I'm going to learn about your clinical needs, and then we're going to come together and we're going to do what's best for our organization. So there are some characteristics that come to play as well.
That's interesting. Go ahead, Doug.
Yeah, this is Doug. So what we try to do is, if we have a chief of service, we approach them first because they already have the ear of the other physicians under that service. And if you don't operate under the physician model of having a chief of service, it is, try to go after the folks, the doctors that, are the informal leaders. And then also, if you're your executive administration, they may have some, they have insight into who those informal leaders or formal leaders are too, so they can also help you. Bottom line, as Stephanie alluded to, they have to be good communicators. They have to champion the cause, and they need to they they will take some mentoring as far as understanding, you know, what does the data mean, and because they can interpret it on a clinical level for the practitioners.
Mm-hmm. That's great, and I've heard that before too. What you're talking about there. So last question. Yep. Mm-hmm. Go ahead.
Benjamin had something he wanted to add as well too.
Yeah, Steve and everybody, I also wanted to add to what they're saying. There has to be, I know Stephanie has said this already, but there has to be that open view to be able to accommodate other vendors, not just because of the fact that you had been using a particular product for the past 10, 15 years, and you're not open to changes. As long as you are open-minded to using other vendors, then it's a win-win situation. And Dr. Chen has been one of our best physician champions in terms of, you know, being open to using, or at least make an attempt to use other products.
Mm-hmm. Well, that's great, and we are probably needing to wrap this up. I do have one more question I think would be really helpful for the audience, whether it be the CRM project or others that they're working on. But it's knowing what you know now about this project. You're done with it. You've got the battle scars. You went through a lot of meetings and back and forth with surgeons and medical device companies. So knowing what you know now, what would you do differently next time?
I think I mean, whenever we have the physician champions, they are, even though they may not be the owner of the budget for the area, they are instrumental for physician preference items in getting the other physicians to listen. So trying that avenue first, get your data together, and then spend as much time as you can in trying to get a physician champion from each of the areas. Now, we are not always successful in doing that, but having one or more physician champions, they really help you out with the vendors. They point the vendors in the right direction when the RFP comes out. You know, even though you want to control the whole discussion related to the RFP or the sourcing event, that's next to impossible. But the physician can control the discussions with your assistance.
Mm-hmm. Interesting. Okay. So go even deeper with that to get the surgeons equipped or the physicians equipped to control and even kind of lead the discussions with the medical device companies.
Yeah, they're with you. They may not necessarily be in lockstep, but they're using you to get what they would like, as well as, you know, it has to be a win-win for both.
Mm-hmm. Yeah, absolutely. Well, it sounds like you did a great project. I hope everyone listening enjoyed this conversation and took away a few nuggets. We're going to have to wrap it up now. I know we could talk for hours about this. It's really interesting. Any last things you want to say, Stephanie? I thought I heard you speak there.
Oh, that was Ben as well too. I'm like I said before. I mean, you approach, you have that wisdom from past projects, but you approach each new project as a new opportunity to learn your physician and to gain more, you know, knowledge about what they do on a daily basis. And you have to really understand they're really trying to do what's best for the patient. And so that's really kind of, you need to always keep that in mind, because they're there every day dealing with families, dealing with patients, and dealing with a lot of stuff that we, quite frankly, don't deal with on a daily basis. So you kind of need to put, you know, yourself in their shoes and really come to understand that they really are trying to do what's best for the hospital. So it needs to be you need to really respect their craft and respect what they do. And I think in return, you'll get that respect. And I think that it may not go as smooth, but I think you'll come out of it, you know, with cultivating a positive relationship, because that's really what it's about, is relationships. And the data and stuff is last. But if we don't respect each other and we don't respect each other's craft and have an understanding, we're both trying to do what's best for the organization, and then come in the middle, I think everything gets lost in translation. Everything else is minutia.
That's a good point. That's good advice. Anything else, Ben? I didn't know if you were going to add.
Yeah, I was just going to add, I think at hindsight, when I'm listening to all this conversation going on, we as in value analysis, we're very, very aggressive in meeting with our physicians in terms of, trying to direct and redirect from that standpoint, supply chain management. But just listening to this and then thinking back, I think we would have used, if we had that opportunity to present yourself again, we would have used more of a physician that chairs the procedural area to communicate with the cardiologists that we had business with more, so that they would speak that lingo, that physician lingo. But I think we didn't do that at the 100% aggressive nature that we always do. But if it presents itself again, definitely we'll use the physician that sits at that committee to communicate with any specialty area.
Yeah, that's excellent. That's a good lesson learned there, and I'm sure you'll get plenty of chances to do that again. So thank you all for taking the time out of your day to do this panel discussion with us. I think there were a lot of good nuggets that everyone got from this. I don't want to volunteer you guys, but I'm sure if anybody who's listening has some additional questions, you could send them to me, and I would then send them over to Stephanie, Benjamin, and Doug and see if we could get some more answers for you. I know in supply chain across the country, there's a lot of good work happening in pockets, and we got to get that work shared, that knowledge shared across the industry. So as a final slide here, reminder that we've got more of these quick 30s, probably should change that to quick 45s or 60s now because the conversations get so good. And but we've got future ones coming. You can see the replays over here. You can go to the Curvo website to get that. And we would love anybody on the call who's done a sourcing project that you've been happy about and you'd like to share. We'd love to do one of these quick 30s with you and interview you on this call. You don't have to be a Curvo user to do that by any means. So Stephanie, Benjamin, and Doug, thank you very much. Really appreciate you guys. Hope you have a wonderful rest of your day.
And thank you for having us.
Thank you very much for having us.
Bye-bye.
Bye.
Yes, bye-bye.